This is the gross image. As we can appreciate, there is a mass. As you can appreciate, there's a tumor mass, irregular borders, yes, and it is quite dull. It is not shiny. It is not shiny like the radial scar. So grossly, you have a mass with irregular margins, okay, which is dull white in color. Can everyone appreciate the cells are quite discohesive? Yes, everyone. The cells are very discohesive. This is occurring because of loss of CDH1 expression or loss of your E-cadherin expression. Now, sometimes if you see the cell is arranged in a pattern, what is this pattern called as? What is this pattern called as? Yes, very easy question. Indian file pattern. Very important MCQ. Indian file pattern. Now, this is the HER2. This is the HER2 chart. Now, see, as I told you in the chromosome number 17, this HER2. Now, these are the two alleles, one from the mother, one from the father. Okay. So, basically, if you see, there's a single HER2 over here in the HER2 negative tumors or in the normal individuals. But for example, if a person is HER2 positive, so there's an amplification of the HER2 in the chromosome number 17. And normally what you will see two dots from the mother, two dots from the father, or anyhow. So over here, if you see in one of the areas, there's an amplification of the HER2. So can you see the increased number of HER2 amplification that can be seen in one of the chromosome? So this is the FISH study. This is that we are looking in the fluorescent in situ hybridization test. Today we are going to discuss a very, very important and interesting topic. Today we are going to discuss about sporadic breast cancer. We have already discussed in details about the familial breast cancer in the previous lecture. And in today's lecture, we will discuss the more common variety of breast carcinoma, that is the sporadic breast carcinoma. So we are going to discuss multiple things for sporadic breast carcinoma, including the molecular part, the gross, the microscopic features, as well as the immunohistochemistry, the grading of the tumor, the staging of the tumor. Okay, all these things we are going to see in details. Okay, so first, as I have already explained before, okay, that you can classify the sporadic breast carcinomas, okay, into three main types. Okay, one is the luminal variety, one is the HER2 positive breast tumors, and we are having the triple negative or the basal variety of breast carcinoma. So first we will start with the luminal variety of breast carcinoma. Luminal is that variety which is ER and PR positive, but which is HER2 negative. It should be HER2 negative and ER positive, which is constituting around 50 to 60% of all the breast cancers. So let us see the molecular part of this. That normal breast, when it is undergoing 1q gain or 16q loss, or it is undergoing germline mutation in the BRCA2 gene that we have already read about in the previous lecture, it leads to a precursor lesion, that is your flat epithelial atypia, which further will undergo PIK3A, 3CA mutation, leading to atypical ductal hyperplasia. The atypical ductal hyperplasia gives rise to DCIs, that is the ductal carcinoma in situ. And this is how they give rise to invasive breast carcinoma of the luminal type. So this is the molecular pathway for the luminal type of breast carcinoma. Okay. Now we have to understand one very important thing, that the ER positive or HER2 negative, that is comprising 50 to 65% of all the carcinomas, which we also call it as the luminal type. Okay, luminal type of breast carcinoma. Now it can be divided into two main parts. Okay, it can be divided into two main parts. So the luminal type of breast carcinoma can either be low proliferation breast carcinoma or it might be high proliferation breast carcinoma. Total, the luminal variety of breast carcinoma is constituting 50 to 60%, and it can further be divided based on the gene expression profiling into low proliferation and high proliferation. So the luminal variety, that is the low proliferation, it is the more common variety, constituting 40 to 55%. Okay, constituting 40 to 55%. Now, first I'm going to discuss in details about the low proliferation luminal variety. It is more common in older women as well as it is common in men, and it is more easily detected by mammography, and it is also common in those women who are treated with hormone replacement therapy after menopause. Okay, now this variety, the luminal low proliferation variety, has the lowest incidence of local recurrence and can be cured by surgery. Okay, if we speak about the metastasis and the relapse of the luminal low proliferation variety, it occurs, but it occurs very late. So it is a good type of a cancer. Long survival with metastasis is also possible. And when metastasis occurs, it involves the bones in 70% cases, viscera in 25% cases, and the brain in less than 10% of the cases. Although this variety is having the ER positive, see, this is the variety which is ER positive. So what do I think about ER positive? ER positive means that they have positive estrogen receptors. So at this point of time, if I am giving any anti-estrogen to the patient, anti-estrogen, okay, then the patient responds to the therapy. So those tumors or those breast carcinomas which are positive for ER, okay, they will respond to the hormonal therapy, that is the anti-estrogen therapy. For example, tamoxifen that we use, okay, it is an anti-estrogen drug. Okay, so the luminal variety, which is low proliferation, they are responding very well to the hormonal therapy, but the response to chemotherapy is very less. They have a very poor response to chemotherapy. Less than 10% of the cases respond to chemotherapy, but most of them, they are responding to the hormonal therapy and they have a very good prognosis. These tumors are usually well differentiated or moderately differentiated tumor. And under the luminal molecular type, okay, there are many special histological types like the lobular variety of breast carcinoma, mucinous variety of breast carcinoma, tubular variety of breast carcinoma, papillary carcinoma. Okay, all these are always ER positive breast tumor. So they are always ER positive breast tumor. So this we have read about the ER positive breast tumors, low proliferation variety. Similarly, we are having a ER positive breast carcinoma, which is high proliferation, constituting 10% of all the ER positive tumors. So total, if you see low plus high proliferation, they are constituting 50 to 65% of all the breast carcinoma. Now, in case of the high proliferation variety, although they are ER positive in nature, but the ER positivity is quite lower as compared to the low proliferation variety. And most commonly, it is this high proliferation variety which is associated with BRCA2 germline mutation. Now, over here, if you look at the mRNA pattern of study is showing an increased expression of genes which are associated with proliferation. So although this set of tumors, they are ER positive in nature, but they are showing excessive expression of genes associated with proliferation. The tumor is also having a higher burden of chromosomal aberrations than the low-grade ER positive tumor, and it has an intermediate relapse pattern. So the relapse pattern is not as good as the low proliferation, but it has an intermediate relapse pattern. Now over here we had seen that around less than 10% were responding to chemotherapy, but over here 10% patients are showing complete response to chemotherapy. Okay, and under this heading of high proliferation ER positive, we have few poorly differentiated carcinomas as well as the lobular variety. Okay, but few lobular variety and poorly differentiated carcinomas, they are coming under the heading of ER positive high proliferation tumors. So I hope you understand this is the first molecular type that we have discussed, that is the luminal type of breast carcinoma. We have discussed the pathogenesis, and we have also discussed that the luminal variety is constituting 50 to 65% of all these sporadic breast carcinomas. Okay, is clear to everyone? The first type, luminal variety, is clear. Luminal variety is that variety which is ER positive and HER2 negative. Now the second group of the second molecular subtype of sporadic carcinoma is your HER2 positive tumors. Now this tumor, they might be ER positive or they might be ER negative, but the most important thing to come under this category is the positivity for the HER2, and approximately they are constituting 20% of all these sporadic breast carcinoma. So it is the second most common molecular subtype of invasive breast carcinoma, and around 15% of these 50% of the individuals are ER positive. Okay, but remember, this positivity is not as strong as the luminal variety. The positivity, when it is present, the expression is very low. So most commonly they are positive in non-white women, in young women, and just like over here in case of our luminal variety, okay, they were associated with germline mutations in the BRCA gene. Also the HER2 molecular type, they also show increased, they are also associated with germline mutation in another gene, that is the TP53 gene. And individuals with germline TP53 mutation, they are part of a syndrome called as Leaf-Romani syndrome. So if you go through the mRNA study, you are going to see that there is an increased amount of HER2 expression, an increased expression of proliferation genes. So not only the proliferation is increased, but also HER2 expression is increased. How do you detect the HER2 presence? By doing immunohistochemistry or even the FISH analysis. Okay, in situ hybridization analysis, fluorescent in situ hybridization analysis. Now, just like the high proliferation luminal variety, this variety is having a very high mutation load. And the cancers in this group, they metastasize when they are very small in size. So the relapse occurs very early, less than 10 years. Whereas in case of the luminal variety, if you see, the relapse occurs after 10 years. Okay. Now, survival with METs in this case is quite rare, whereas survival with METs was much more possible in case of luminal variety of breast carcinoma. Now, the metastasis, again, they have the same distribution. It most commonly involves the bone in 70% cases, 45% cases involves the viscera like the liver, pancreas, and 30% cases it involves the ipsilateral breast. Okay, so over here, okay, 30% cases, this is involving the brain, not the breast. It is metastasizing to the brain. Okay. Now, all this thing and a very bad prognosis was there before the HER2 targeted therapy was there. Can anyone tell me what is the drug of choice for HER2 positive breast carcinoma or HER2 positive tumors? It is trastuzumab. It is trastuzumab. So before any drug was available which can go and block the HER2 receptor, okay, the outcome was very poor. But now 1/3 or more patients, they completely respond to trastuzumab, and those patients who are responding to this drug, they have an excellent prognosis. But not all patients are having. But one thing that has happened that now, or not all of the HER2 positive tumors are responding to therapy. So that is a problem. As I told you, only 1/3 or little bit more, less than 2/3 patients are responding to the trastuzumab therapy. But even those who are responding, they are becoming resistant to the therapy after few years. Okay, because this HER2/neu becomes truncated form. So the truncated form of HER2/neu, it is resistant. It is resistant to trastuzumab therapy as well. Now, the response to chemotherapy. So those cases which are ER negative, more than 30% of those HER2 positive and ER negative cases, they are responding to chemotherapy, whereas only 15% of HER2 and ER positive tumors are responding to chemotherapy. So you always remember, as the tumor becomes more bad and has a higher proliferation rate, they will respond better to chemotherapy. Okay, is it clear? All the points with regards to the HER2 positive breast carcinoma. Now, this is very important for you because even in surgery, when you are going to read about the breast, all these important questions are asked in your MCQ exam. Okay. Okay. Now, after this, which histological types they are corresponding to the HER2 positive? The apocrine carcinoma of the breast and the micropapillary carcinoma of the breast are responding to this histological type. Okay. Now, if you look over here, the normal breast, okay, if they are having germline TP53 mutation in case of Leigh-Fraumeni syndrome or HER2 amplification in chromosome number 17, it is leading to a precursor lesion that is called as atypical apocrine adenosis, which gives rise to ductal carcinoma in situ, and that is finally giving rise to invasive breast carcinoma, which is HER2 positive. Okay, this is comprising 20% of all these sporadic breast carcinoma. So is it very clear? Yes, the second variety, that is the second molecular type. And the third important molecular type, that is negative for ER, PR as well as HER2. It is also called as triple negative breast carcinoma. Triple negative. And this is the one which is having the worst prognosis, comprising 15% of all the breast carcinomas. Now, over here, the normal breast, okay, again over here, unlike the luminal and the HER2 variety, no precursor is identified yet for the triple negative breast carcinoma. And this is associated with TP53 mutation as well as BRCA1 inactivation, giving rise to ductal carcinoma in situ. So there is no atypical hyperplasia. Directly, the normal breast is converting into the DCIs. Okay. And this is giving rise to invasive carcinoma, which are triple negative. They are ER negative, PR negative, HER2 negative. And they are comprising 15% of all the sporadic breast carcinoma. We also call it as the basal-like or myoepithelial-like. Myoepithelial-like. Okay. Also called as the myoepithelial-like. Now, it is the third major molecular subtype that we see. It is most common in very young premenopausal African American, and they harbor BRCA1 germline mutations seen in Hispanic women. The mRNA expression, again, they show an increased expression of proliferation genes. Okay, very, very important. Remember, 10% of the basal-like tumors might express ER and 15% might express HER2. Okay, so what is the importance? So any person, okay, any basal like tumor, if it is there, it should always be screened for ER and HER2, because 10% of the basal like tumor might express ER and 15% might express HER2. Now you tell me why it is important to find ER and HER2 positivity. Yes, if any tumor is coming out to be positive for ER, we can give anti-estrogen therapy. So we can start with tamoxifen. If any patient is coming, if any tumor is coming out to be HER2 positive, what we can give? Trastuzumab we can give. Okay, so that is why it is very important. And nowadays in any college, if you see, if you visit the pathology department, after they complete the breast carcinoma surgery, they are carrying out immunohistochemistry, because they want to know whether they are ER positive or HER2 positive or they are triple negative, because they will start the treatment accordingly. Now, again, these tumors, they are aggressive tumors and they can metastasize even when they are very small. And survival with metastasis is very rare. So relapse is less than 5 years only after, the diagnosis, the patient will relapse after the treatment. Okay. Now, because these tumors are having a very high proliferation gene, so 30% of the patients are completely responding to chemotherapy. Now, the histological types of breast carcinoma, which is corresponding to the basal variety, is carcinoma with medullary features, metaplastic carcinoma, adenoid cystic, and the secretory variety. I am going to show you all the different histological types. So stay tuned till the end of the lecture. Now, this is the diagram, as I was telling you, the diagram for the luminal variety, which is the ER positive and HER2 negative, HER2 positive, and the triple negative breast carcinoma. As I told you, the luminal variety can be low proliferation, can be high proliferation. So if you are carrying out an mRNA study, so in the lower half, you have the proliferation genes. In the upper half, you have the HER2 expression. In the uppermost, you have ER regulated genes. So what you see over here in case of the luminal variety, okay, the ER positivity is there, but in the the luminal low proliferation variety, if you see, they are ER positive and they are highly ER positive, but they are negative for HER2 and they are negative for high proliferation. So they are low proliferation. For the high proliferation, if you go do the mRNA study, you will see that some amount of ER positivity is there, but it is less as compared to the low proliferation variety. Now, HER2 again is negative, but again, if you see, they have genes for high proliferation. So any condition where there is a high proliferation index, they will respond better to chemotherapy. Okay, always remember this point. In case of HER2 positive tumor, as we can see, they are positive for ER in few cases, but they are also positive for HER2. So they become HER2 positive, and they also have high proliferation gene positive. So they can proliferate very fast. Whereas in the triple negative variety, ER is negative, HER2 is negative, just high proliferation gene is there. Okay, is it very clear when I'm speaking about the proliferation genes? Now, is it very clear to everyone? Okay. Okay, this is just I wanted to show you in this particular diagram. Now, this is the same molecular pathogenesis of sporadic breast carcinoma that I had discussed with you. So there are three important pathways. Okay, number one, the sporadic invasive breast carcinoma can be divided into three main parts. One is the luminal variety, one is the HER2 positive tumor, one is the triple negative breast carcinoma. Luminal variety can be low proliferation and can be high proliferation, as I have discussed. Okay. Now, the first pathway, as I have already discussed, the normal breast with 1q gain or 16q loss, or if it is in the germline, BRCA2 mutation, if it is there, leading to flat epithelial atypia followed by atypical ductal hyperplasia, that is followed by ductal carcinoma in situ, and then we are having invasive carcinoma of the breast. Okay, followed by the second pathway, that is the HER2 positive tumors. If you see over here, you have Leaf-Romani syndrome. The TP53 mutation occurs in the germline, HER2 amplification in chromosome number 17. No definite precursor is identified, although atypical apocrine adenosis has been suggested. Atypical apocrine adenosis has been suggested as a precursor, again giving rise to the DCIS. And finally, you have the HER2 positive cancer comprising 20% of all these tumor. And the last molecular pathway which occurs, if it occurs in the germline, in the familial case, they show BRCA1 mutation. Along with that, TP53 mutation, along with BRCA1 inactivation, will lead to DCIs. So directly from the normal breast, you are going to DCIs, and over here, these are triple negative breast carcinoma having the worst prognosis, comprising 15% of all the breast tumor. This is very, very, very important. Thousands of questions are being asked from this portion. From surgery also, you will have this particular part. Okay. So is this very clear? The molecular pathogenesis of sporadic breast carcinoma? Yes, the pathogenesis of ER, HER2 and triple negative breast tumors. Is it very clear to everyone? Okay.
Yes.
Now this is the HER2. This is the HER2 chart. Now see, as I told you in the chromosome number 17, this HER2. Now these are the two allele, one from the mother, one from the father. Okay. So basically, if you see, there's a single HER2 over here in the HER2 negative tumors or in the normal individuals. But for example, if a person is HER2 positive, so there's an amplification of the HER2 in the chromosome number 17. And normally what you will see two dots from the mother, two dots from the father, or anyhow. So over here, if you see in one of the areas, there's an amplification of the HER2. So can you see the increased number of HER2 amplification that can be seen in one of the chromosome? So this is the FISH study. This is that we are looking in the fluorescent in situ hybridization test. And this is the immunohistochemical analysis. Now over here, if you see it is HER2 negative. Okay, there is no stain. But over here, this is the HER2 positive. Now HER2 positive, there is a criteria from the WHO. There should be complete membranous staining. You can see that around the cells, okay, like this. Over here, if you see, there is a brownish coloration of the membrane. Okay, and this brownish coloration of the membrane or staining of the membrane, complete and intense staining is taken as a positive for the HER2. Is it very clear to everyone how we can see the HER2 positivity? If these diagrams are shown in the exam, so you should be able to answer if it is HER2 positive or HER2 negative tumor. Okay. Now we will classify the breast tumors. Okay, so breast tumors can be classified into 6 main types. One is your epithelial breast tumor, fibroepithelial tumors and hematomas, tumor involving the nipple, mesenchymal breast tumors, and lymphomas of the breast. So the most important among this category is the epithelial tumor. So under this, we have the benign proliferation, that is the UDH and the ADH that we have already discussed in the benign breast tumors. Then we have sclerosing adenosis, we have adenomas, then we have papillary neoplasms, non-invasive lobular neoplasia, which contains ALH, atypical lobular hyperplasia, along with lobular carcinoma in situ. Then we have ductal carcinoma in situ, and then we have invasive breast carcinoma. Now, invasive breast carcinoma can have several types. The most common being invasive ductal carcinoma NOS, no other special type, lobular carcinoma NOS, tubular carcinoma NOS, cribriform carcinoma, mucinous carcinoma, metaplastic carcinoma, apocrine carcinoma, and secretory carcinoma. I will show you in details the histopathology of all these different tumors. And in the end, we also have neuroendocrine tumors involving the breast. So all these, they come under the epithelial tumors of the breast. Now, looking at the other looking at the second heading is the fibroepithelial tumors and hematomas. So under this, there is an hematoma. And along with that, there's a fibroepithelial tumor, that is, we have fibroadenoma along with the phylloids tumor, which we have already discussed. Now, at the level of the nipple, you can have an adenoma, and you can also have the Paget's disease, which we have discussed in the previous lecture. And then we have the mesenchymal tumors. Now, mesenchymal tumors can be present in any organ, and all of them, they have the same heading. So there can be vascular tumors like hemangioma or angiosarcoma or lymphangioma or angiomas. There can be fibro and myofibroblastic tumors, like there can be fibrosarcoma, there can be nodular fasciitis. There can be peripheral nerve sheath tumors like neurofibroma and schwannoma. Smooth muscle tumors like leiomyomas, leiomyosarcomas can be there. Adipocytic tumors like lipoma and liposarcomas. So mesenchymal tumors is present in all the body, Mesenchymal tumors along with the lymphomas. Or lymphoproliferative tumors can also occur at the level of the breast, like DLBCL can occur, follicular lymphoma can occur, any kind of lymphoma, non-Hodgkin's lymphoma can occur at the level of the breast. Sixth, we have the male breast tumors. We have gynecomastia and we have infiltrated ductal carcinoma, NOS. This is the basic classification of the tumors of the breast. Okay. If you are asked, you have to write down about them. Now, coming to the very important thing is the morphology of the breast carcinoma. Now, very important, breast has a lot of morphological appearance, and around 1/3 of the breast carcinoma can be classified into special histological type. What is the special histological type? So all this that we have written over here, these are called as special histological type. Whereas the one which is not having, which is the most common, which cannot be classified into this group, this forms the most commonly diagnosed, that is IDC NOS, infiltrating ductal carcinoma NOS. Okay, so only 1/3 can be classified into special histologic type. Now, why it is important to classify? Because these special histologic type has different kinds of prognosis. Now, most commonly, as I had already told you, is the ductal carcinoma NOS. Now, if you do a mammography, you are going to see a hard, irregular, radiodense mass, which is associated with desmoplastic stromal reaction. Desmoplasia means increased fibroblastic reaction, increased fibrosis. So if you cut a tumor, if you cut a breast tumor, they will have a characteristic grating sound. I will show you the diagram. Grossly, before the invasive breast carcinoma is detectable, it grows to 2 to 3 centimeters in size. Now, larger carcinomas might also invade the pectoralis muscle, and they can become fixed to the chest wall. So once the breast tumor is fixed, if this is the breast, okay, if this is the breast, okay, now, and if this is the tumor, it can either grow into the chest wall and involve the pectoralis muscle, or it can involve the skin. So when it is involving the skin or the chest wall or the dermis, it is causing what is called as retraction of the skin or dimpling. So this area will be dimpled, or it will retract. It is called as a dimpling. If this growth is involving the nipple directly, it is going to cause retraction of the nipple. Okay, that is going to cause nipple retraction. So skin retraction or nipple retraction in a female is a very important sign of breast carcinoma. Rarely, the breast carcinoma might present as an axillary lymph node metastasis only, without any mass. Okay, so it points at the occult primary. If you do an MRI, you will see a very small tumor which is there inside the breast, which was not detected clinically. So this is the very important mammography pattern. If you can appreciate, yes, can everyone appreciate? Can you see the outline of this calcification or this desmoplasia that is there? Yes, everyone. Is it well circumscribed? No, it is not well circumscribed.
Irregular margin.
There is a haphazard pattern of a stromal invasion with irregular margins on imaging. This is your invasive carcinoma of no special type. That is the NST variety, no special type. Okay. So this is the gross image, as we can appreciate. There is a mass, as you can appreciate. There's a tumor mass, irregular borders. Yes. And it is quite dull. It is not shiny. It is not shiny like the radial scar. So grossly, you have a mass with irregular margins, okay, which is dull white in color. Now, as we can see, breast is composed of different kinds of ducts. So tumor which is arising from the TDLU, it is also comprised of what? The different types of glands. So can you appreciate over here the different kinds of pleomorphic glandular structures? Yes. So this is the most common histopathological slide of the breast, the IDC NOS, where you can see ductal adenocarcinoma, breast adenocarcinoma, because it is arising from the glands. And these are all, these are all invasive glands. Okay, they have invaded. And if you appreciate, what is this? What is this area? This is your desmoplasia. This is the area of desmoplasia. A lot of fibrosis has taken place at this particular point. A lot of fibrosis has taken place. This is your desmoplasia, as we can see. Okay, the tumors are marked by exuberant desmoplastic stroma. Even if you see from outside, can you see there is so much of fibrosis? And if you cut across it, it is going to create a grating sound when you cut across this tumor. Okay. Now, as I told you, that breast carcinoma, okay, this is the most common, this should be the most common type of presentation. But as I told you, breast carcinoma, it is very heterogeneous. It can have any kind of presentation. So sometimes under mammography, you are going to see a mass which is very well circumscribed. So you might think that this might be a benign tumor. But when you go for the biopsy, you might become surprised. See, tumor can grow in two fashion. Okay. One fashion is this, that for example, this is the gland. For example, this is a tumor. Okay, it might grow like this. It might infiltrate like this. Or the tumor might grow in this fashion. See, It might grow like this. It might. So this is called as the infiltrative. That we had seen before. This is the infiltrative variety, and this is the one which is having pushing margins. Pushing. It is pushing. It is also invasive, but it is having a pushing margin. Okay. So sometimes a small set of breast carcinoma might be very well circumscribed. Okay. Now, if you see on the gross section, can you appreciate a very well circumscribed mass? Yes, so you might think it might be a fibroadenoma, it might be a benign tumor of the breast. But the same breast, okay, when we had seen under the microscope, can you see this? What is this? This is an atypical mitotic figure. Atypical mitosis is there. Can you appreciate these cells? Yes. Can you appreciate? These are all pleomorphic cells. These are all pleomorphic cells. Desmoplasia is not that much. You cannot see a lot of fibrosis over here. That is why in this tumor also you cannot see fibrosis. Compare it with this one. There was lots of fibrosis. Okay, and over here also we can see lots of desmoplasia. Over here there is desmoplasia is not that much. Limited narrow zone of fibrosis is there, and you can see that how and they are invading in a pushing front. Okay, they are pushing the tumor. Okay, expansile masses of cells with pushing borders. Okay, with limited zone of fibrosis. Now, sometimes what happens? Sometimes under the microscope, under mammography, if you see, you cannot appreciate a clear-cut mass. You cannot see this. This is looking like a normal breast density. Looks like normal breast density looks like this under the mammography. So sometimes under mammography, you might not be able to appreciate any kind of mass. So even if you see grossly, you can just see fat. Maybe some whitish areas are over here, but you cannot see anything grossly also. Might be some area of thickening is there if you feel. But under the microscopy, in between the fat that you see, there are tumor cells in between the fatty region. Yes, everyone is able to appreciate. So microscopically, the tumor cells are found scattered with normal appearing fibroadipose tissue. In between, you have the fat tissue, normal fat, and you have in between, you are having the tumor cells. Okay. So breast carcinoma, why I have showed you? I have showed you because they can have many kinds of presentation. Okay. Clear to everyone? Now, this is the classical, gross presentation of a breast. This is the infiltrative variety that we have watching. Why have I shown you? To show the irregular margin of the tumor and to tell you that how they are looking dull white, how they are dull white in color. Okay, they are dull white, showing extensive areas of fibrosis, irregular infiltrative margins. Okay. Now, what is this? Yes, can anyone tell me what is this finding? What is this? It is the nipple retraction that has taken place. There is a nipple retraction. Okay, so it is pointing towards underlying malignancy, breast tumor. So very, very important that histologically there is a very important grading. It was asked in AIMS, what is the name of the grading that is there and what are the components of the same? It was there that all of the following are the components of the Nottingham grading. So this is very important for the postgraduate, but at least the undergraduate, you should know that this Nottingham grading is there for breast carcinoma to grade the tumor as well differentiated, moderately differentiated, or poorly differentiated, grade 1, 2, 3. So obviously the grade 1 tumors are having a better prognosis as compared to the grade 3 tumors. Okay. So we are going to see what are the components. You don't have to remember all the scoring, just to remember that what are the things that we are using, okay, histologically for grading. So very important, one is your tubule and gland formation, nuclear pleomorphism, and mitotic count. Taking this into consideration, we have a particular score, and depending upon the final score, if the score is between 3 to 5, it is a grade 1 tumor, also called as well differentiated breast carcinoma. If there is the score is 6 to 7, it is the grade 2, it is the moderately differentiated breast carcinoma. If the score is 8 or 9, it is grade 3, it is poorly differentiated breast carcinoma. So this is very, very important. Okay, so you, for the undergraduate, just the name Nottingham grading. This is the histological grading. Okay, there are 3 grades, and the 3 parameters are the tubule and gland formation and the nuclear pleomorphism along with the mitotic count. Is this very clear? The Nottingham grading, it is for breast carcinoma, for invasive breast carcinoma. Yes, clear to everyone? This is a very important image which is taken from Robbins. Now, I will just tell you in a very short way how to understand this. See, if you have more amount of tubule formation, if you can see more tubular structures, okay, that means they are well differentiated. Now, in the second image, so this becomes the grade 1 or well differentiated breast carcinoma. This is the grade 2. Now, over here, you can see very few tubular structures, and even the cells are pleomorphic and the mitosis is very high as compared to grade 1. So this becomes your moderately differentiated grade 2 breast tumors, breast carcinoma. Then comes the grade 3, that is the poorly differentiated breast carcinoma. Over here, can you see any tubule formation? See, tubule formation is not there. Even the cells are highly pleomorphic and mitosis is very less. If you understand, it's all right. If you don't understand, at least remember the grading, the name, and you remember what are the components of this grading system: tubule and gland formation, nuclear pleomorphism, mitotic count, and there are 3 important grade 1, 2, 3 well, moderate, and poorly differentiated tumor. Clear to everyone? Yes, can we move ahead? Okay. Now, very important, as I told you today, just the diagnosis of breast carcinoma cannot help us. We need to carry out immunohistochemistry. Why? Because we need to know whether a tumor is ER positive breast carcinoma, or it is HER2 positive, or it is triple negative breast carcinoma. We need to understand this, because without this information, we cannot start the treatment. See, if it is ER positive, I will give anti-estrogen therapy. If it is HER2, I will give trastuzumab. If it is TNBC, we will give chemotherapy to the patient. So we need this information. As a clinician, you have to ask for this information in case of breast carcinoma. So always remember, presence of ductal carcinoma in situ in the nearby breast of the invasive breast carcinoma is indicating origin from the breast. Also, the markers of primary, see, if you are taken, if for example, you have taken, or there's a tumor inside the breast. So how you will know that it has arisen, the tumor is arising from the breast and it is not a metastasis from the GIT or some other part. So breast tumors are always ER, PR along with GCDFP15, gross cystic disease protein 15 positive, GCDFP protein. All these 3, if it is positive, that means it is a primary breast carcinoma. It is arising from the breast. Very, very important MCQ which is asked. Okay. Now, if you have to give a panel of markers to rule out, for example, which markers you will give. So to the breast, okay, lung or thyroid carcinomas can go. So we will give TTF1, TTF1. If it is coming out to be positive, that means it is the origin is from the lung or the thyroid. Then we use WT1. If it is the adenocarcinomas arising from the ovarian serous, okay, or from the ovarian tumor, then it is WT1 positive. If it is endometrioid variety of ovarian carcinoma or endometrioid tumor, it will be Vimentin positive. And to rule out your colorectal carcinoma, you give CDX2. So these are all the additional markers to rule out metastasis from the other sides. Okay, clear everyone? Immunohistochemistry. What are the markers you are going to do? Now, according to the latest WHO, taken from the WHO, just you have to understand for the ER and PR positivity, when are you going to say that the immunohistochemistry ER, PR is positive? So this is the positive slide. Okay. And they show nuclear positivity. Both ER, PR, they are showing nuclear positivity. And very important, WHO has given more than 1% cells, they are positive. Then we take it as ER or PR positive only. The interpretation should be positive. If less than 1% or 0% cells stain positive, then it is taken as a negative. Okay, very simple. Now, similarly for the HER2, as I told you, for the HER2, okay, there is a different scoring system. Now, now only HER2 score 3 is taken as positive, and they show membranous positivity. Only the membrane is stained. Whereas over here, if you see in case of ER, there is a nuclear staining. So remember this thing. Over in ER-PR, it is the nuclear positivity. Over here, there is a membranous positivity. And this positivity should be of very high. So there should be completely, the membrane should be positive and high intensity positive. Only the score 3 is taken as positive. HER2 score 3 is only positive. If the score is 2+, it is equivocal. That is, you have to carry out FISH study or other investigations has to be done to confirm. Score 0 and score 1 are regarded as negative HER2. Okay. Is it very clear to everyone about the ER-PR positivity and HER2 positivity and what is the importance, why we need them? Yes, for molecular division for molecular classification, it is required. Any doubts anyone is having till here? Yes. Any doubts? Acha. Anyone having any doubt? Can we move ahead now?
सर ER-PR के लिए आपने बताया न्यूक्लियर और बताया ना आपने
ER-PR, the positivity is nuclear. What do I mean is that, for example, if this is the cell and if this is your nucleus, okay, then that means if I am giving a particular brown stain and if it is just staining the nucleus, then it becomes nuclear positivity. For example, if it is staining the membrane, then it becomes membranous positivity. Is it clear? HER2 will show membranous positivity, ER-PR will show nuclear positivity. Yes, clear to everyone now?
Okay. Yes, sir.
Now coming to the special histologic types of invasive breast carcinoma, very, very important. Why it is important, we will see. See, we are always doing the immunohistochemistry to know whether they are luminal or they are HER2 or they are TNBC. Now, very important thing is which are the tumor. Now, there is some histological points. So we can morphologically diagnose a particular tumor. Yes. And we can basically go for a luminal diagnosis as well. Okay, so very important is special histological types of breast carcinoma often harbor unique genetic aberrations and have unique clinical features and prognosis. So for example, the luminal positive carcinoma, which is ER positive, okay, they are corresponding to such morphologies like lobular carcinoma, mucinous carcinoma, tubular carcinoma, papillary carcinoma. Usually they have a very good prognosis. These tumors having a good prognosis. HER2 positive tumors, they are corresponding to apocrine or micropapillary carcinoma, and triple negative breast carcinomas are corresponding to metaplastic carcinomas and carcinomas with medullary features. Okay, carcinoma with medullary features. Now remember, although secretory adenosquamous and adenocystic carcinoma, they are also triple negative breast carcinoma, but they have a very, very good prognosis. They have a very, very good prognosis. Is this clear to everyone? Okay, now we can start. We will start with the first important special histological type, that is the lobular carcinoma of the breast. Now, as I told you, just like in case of your diffuse infiltrating variety of gastric carcinoma, here also there is a loss of CDH1 expression, which is encoding for the E-cadherin protein. Now, I have already told you before in case of gastric carcinoma, that is this E-cadherin is responsible for keeping or holding all the cells together. Okay, if the E-cadherin cannot function, then the cells will become discohesive. Okay, so that leads to the discohesive single cell infiltration of the cells. So I will just show you this particular diagram. Can everyone appreciate the cells are quite discohesive? Yes, everyone. The cells are very discohesive. This is occurring because of loss of CDH1 expression or loss of your E-cadherin expression. Now, sometimes if you see the cell is arranged in a pattern, what is this pattern called as? What is this pattern called as? Yes, very easy question. Indian file pattern. Very important MCQ. Indian file pattern. It is called as Indian file pattern, also called as single files of cells. It is classical feature of lobular carcinoma of the breast. Okay. Now, very importantly, metastasis of lobular carcinoma involves the peritoneum, retroperitoneum, and the leptomeninges. Now, patients with the germline mutations of CDH1, they have an increased risk of not only breast lobular carcinoma of the breast, but also signet ring carcinoma of the breast. Among all the special types, I'm saying among the special types, not overall. Overall, the most common is invasive breast carcinoma, NST, that we have already discussed. But among the special varieties, the most common is your lobular carcinoma. It occurs most commonly in the post-menopausal women and in older age women. And these tumors have a lower histological grade. They are often bilateral and they are multicentric in nature. So they are bilateral tumors and they are multicentric in nature. Okay. What do you mean by multicentric? Yes. Can anyone tell me? Bolo? Yes. What is multicentric? See, bilateral means if this is the breast, it will involve this and this too. Multicentric means if you divide the breast into 4 quadrants, it will be present in multiple other quadrants. Now, is it clear to everyone? It is bilateral and multicentric. Very important. Yes, even in surgery questions, you are going to get this question. Now, remember, lobular carcinoma doesn't produce that much amount of desmoplasia, so it might be missed by imaging studies. As I showed you one particular variety, it didn't have. Yes, is it clear to everyone? Okay.
Yes, sir.
Okay. After that, very important is, if you go for the histopathology, as I told you, the lobular carcinoma gradually infiltrates the breast while producing minimal fibrosis or desmoplasia. So you cannot see a lot of fibrosis. Very little fibrosis is there. Okay, and it is infiltrative in growth. It is infiltrating. The cells are discohesive in nature, and sometimes they are producing signet cells also. Now, what are the signet cells? Can you see this cell? This is a signet cell which has produced mucin and pushed the nucleus towards the periphery. Okay, this is your signet cell. Such kind of signet cell is also seen where? Yes, where are they seen? Such kind?
Gastric.
They are also seen in your gastric carcinoma. Very good. They are seen in the diffuse infiltrative variety of gastric carcinoma as well. Okay. Now, the second important special type is your invasive variety of tubular carcinoma, which, as the term is suggesting, they are having well-formed tubules. Okay, elastosis is present and little nuclear pleomorphism, whereas mitosis is very rare. Now, for the diagnosis of invasive tubular carcinoma, more than 90% should show tubules. Okay, so can you see? Can everyone appreciate? Yes, there are well-formed tubules. Yes. Now, in the benign area, we had read about a lesion called as complex sclerosing, not complex sclerosing. We had read about sclerosing adenosis. We had read about adenosis. Do you remember? Sclerosing adenosis. Even that had the similar picture. If you see, they were having increased amount of TDLUs like this. There was increased glands. Adenosis was there. So how do I differentiate this from sclerosing adenosis? Very important. If you see over here, they just have a single layer of ductal cell. No myoepithelial cell is present. Can you appreciate any myoepithelial cell? That is not present. So that is differentiating this from that benign entity. Okay, clear to everyone? Now the invasive cribriform pattern. Cribriform means a sieve. Sieve means a chakni, means which is having holes that we use for rice or for for taking out any kind of other dust or grains from the rice. We are using a sieve. So cribriform means sieve. So this tumor has an excellent prognosis, and histopathologically they are sieve-like. Why I'm saying it is like a sieve? Can you appreciate? This is the entire tumor and it has holes inside of it. This is called as the cribriform pattern. Can you appreciate? This is the cribriform, as if you are sieving. Okay, this is your cribriform pattern. Okay, again, this is having a very good prognosis, just like a tubular variety, and this pattern should be present in 90% of the lesion, so as to label it as the invasive cribriform carcinoma. The fourth important is your invasive mucinous carcinoma, also called as colloid carcinoma of the breast. Now, very important thing is the cut surface grossly is highly gelatinous, and the borders are quite pushing and circumscribed. So I have already explained the difference between infiltrative and pushing or circumscribed border. So histopathologically, what you are going to see, very important thing, that you can see islands. What is this? This whitish area? Yes, can you tell me what is this whitish area? It is the areas of mucin production. Okay, it is the areas producing mucin. And these are islands and clusters of the tumor cells which are floating in the island of mucin. This is the characteristic feature of mucinous or colloid carcinoma. This is the mucin material. And to call it as such, 90% of the area should have mucinous histology, and they are positive for MUC2 and MUC6, and they have a very favorable prognosis. This is the invasive mucinous carcinoma of the breast. This is second diagram, the same high power view. This all area is mucin positive. And if you can appreciate, these are the tumor cells. These are the breast tumor cells which are producing the mucin. Now, carcinoma with medullary pattern. Now, remember, previously, okay, there was a separate entity called as invasive medullary carcinoma of the breast. But now, all this tumor which is having medullary pattern, it is coming under invasive ductal carcinoma, no special type. Under this only you have to add with medullary features. Okay, with medullary features. Why I am saying? Because before it was believed that the medullary carcinoma of the breast has a very bad prognosis because they are triple negative tumors. But later on, it was seen that it is not having such a very bad. In fact, it is having a very good prognosis in comparison to other triple negative breast tumors. So 50% of this medullary carcinoma tumors, or tumors with medullary pattern, has BRCA1 mutation associated. Okay, and over here there is no mutation. Instead, there is epigenetic change. There is a hypermethylation and silencing of the BRCA1 gene, leading to a decreased BRCA expression. It has a better prognosis than other poorly differentiated triple negative breast tumors. Why it is so? Because this tumor is having an increased amount of T lymphocytes. Okay, and that T lymphocyte is providing the protection against the cancer. Okay, that is responsible for the better prognosis. It is usually triple negative, ER, PR, HER2 negative. Grossly, if you see, there is minimal desmoplasia and they are often well circumscribed tumor. But histopathologically, there are very important points that you should remember. These tumors are growing as a solid sheet of large cells with pleomorphic nucleus and very prominent nucleoli. Frequent mitotic figures are there. They have a lot of lymphoplasmacytic infiltrate, and very important, they have a pushing border. They have a pushing border, and very important, the cells are growing in a syncytial pattern. Means multiple nucleus are together. This is the meaning of syncytia. Okay. So if you appreciate over here, this is the cell. Can you appreciate they are highly pleomorphic, having prominent nucleoli? Yes. They are growing as a pushing border. They are pushing. And what is this? This is the lymphoplasmacytic infiltrate. This is the lymphoplasmacytic infiltrate. Okay. These are the pleomorphic tumor cells as we can appreciate over here. Okay. Lots of mitotic figures as we can appreciate. Lots of mitotic figures are there. Okay. And they are growing in a syncytial pattern. Okay. So this is your medullary carcinoma. That is the tumors with cancers with medullary features. Okay. Clear to everyone? Then lastly, we will see that the metaplastic breast carcinoma, which is the triple negative breast carcinoma. This is the definition. It is a heterogeneous group of invasive breast carcinoma, and it is having a mixture of malignant epithelial component. So the malignant epithelial component is the normal adenocarcinoma that we are looking at. Along with that, they have a metaplastic abnormal malignant squamous epithelium differentiation. Along with that, some malignant mesenchymal elements like your cartilage, bone, spindle cell, myxoid stroma will be present. So it is a mix of both epithelial plus mesenchymal components are there in metaplastic breast carcinoma. Okay, they have both epithelial and mesenchymal components. So look over here. This is your classical, this is your metaplastic squamous cell, metaplastic abnormal malignant squamous cells. And along with that, what you can appreciate is the spindle cell, the mesenchyme, the spindle cells or the mesenchymal differentiation. They might have cartilage or bone also in the background. This is just, so along with the usual areas of breast adenocarcinoma, they are having metaplastic features and they are having mesenchymal elements. Then we are using the term metaplastic breast carcinoma. They are triple negative breast carcinoma and they have a very, very poor prognosis. Okay. Then we have the inflammatory breast carcinoma. Now remember, this is more of a clinical diagnosis. Now grossly, the breast is presenting with a swelling, redness and thickening of the skin. Okay, the breast is presenting with swelling, redness and skin thickening. Now over here, what happens? Now the breast is swelling because of extensive blockage of the lymphovascular space of the dermis by the carcinoma cells. So whatever cells are there, they cause plugging. So the lymphatics are not drained, leading to the breast swelling. Okay, very important. Now the skin is tethered to the breast. If you see, this is the skin outline and this is the breast tissue, and the breast tissue is attached to the skin by means of a ligament. This ligament is called as a
Cooper ligament.
Cooper's ligament. Very important exam question again. So what happens that when the skin is attached, the skin remains attached. Now because of the swelling, what is going to happen? This area is going to become like this, and some areas over here is going to stay back where the attachment is there. And this is responsible for the classical appearance of pudy orange appearance. That is the orange peel appearance. Okay, because the breast tissue, okay, is attached to the skin by means of the Cooper ligament, and there is an edema. Okay, so as a result, what is happening, that particular part is stuck to the skin. Okay, and as a result, that part cannot come forward, leading to a classical pudy orange appearance. Let me just show you. Can everyone appreciate this breast? Can you see this? It is looking like an orange peel or no? Yes. There is a lot of inflammation. There is a lot of redness and erythema. Okay, usually a well-defined breast tumor mass is not seen usually. Okay, and remember, once the diagnosis of inflammatory carcinoma is made, it is actually stage 4 tumor. It is P stage 4 tumor. Okay. Now it is the name inflammatory is a misnomer. No inflammatory cells are present over here. Histopathologically, the tumor cells are diffusely infiltrative. There is no mass, tumor mass is not seen. A very high grade tumor with a very poor prognosis, and no special molecular subtype is associated. And most patients are presenting with distant metastasis in case of your breast carcinoma, that is the inflammatory carcinoma of the breast. Okay. Now, very, very important question is the prognosis of the breast carcinoma, asked as a long answer question. Okay, so what is the prognosis? Now, it depends upon the biological features, whether it is ER positive, HER2 positive, or it is triple negative, or what is the histological type, whether it is metaplastic, lobular. So now you understand why I have explained you all the different special types, and also depends on the stage of the disease at diagnosis. What was the stage at diagnosis? And also, patients who are presenting with metastasis or those who are presenting with inflammatory carcinomas usually have a very bad prognosis. So the first important factor over here is lymph node metastasis. Now, the most important factor or prognostic factor is distant metastasis. But second to distant metastasis, the most important prognostic factor is axillary lymph node status. Now, why it is important? So if breast carcinoma is there without any axillary lymph node involvement, the 10-year survival is 70 to 80%. If 1 to 3 positive nodes are there, then the survival drops down to 35 to 40%. And if 10 or more axillary lymph nodes are positive, the 10-year survival drops to only 10 to 15%. So it is very important. The axillary lymph node important is a very important prognostic indication. Now, I hope you all understand what is the meaning of a sentinel node. Now, sentinel node is that node which is the first draining lymph node of that particular tumor. So for case of a breast carcinoma, breast tumor, the first sentinel lymph node is either your axillary lymph node or your internal mammary. But most important is your axillary lymph node. So what we will do, we will take a biopsy from that first sentinel axillary lymph node. If it is negative, then it is unlikely that the tumor has a spread. Okay, so if the biopsy from the sentinel node is negative for metastasis, it is unlikely that other lymph nodes are involved. So the tumor has not metastasized. That is the importance, because if the metastasis is present, you have to carry out complete axillary lymph node dissection. And this is a very, very painful surgery, because after this surgery, lymph nodes cannot flow from the breast, and there is a swelling of the entire hands region. Okay, so as a result, and this is also increasing the risk of some sarcomas in the hand. Okay, so to avoid this, we are doing the sentinel lymph node biopsy. Now, the second prognostic factor is the distant metastasis. As I told you, it is the most important prognostic factor, and once metastasis is there, the cure is unlikely. Then is your tumor size. Now, as your size of the tumor will increase, the chances of metastasis also increases. So the tumors or node negative means where the tumor has not metastasized. So carcinomas less than 1 centimeter, for the 10-year survival is more than 90%, but whereas those who are 2 centimeters and above, the 10-year survival is 77% only. So these are node negative tumors. Now, locally advanced disease. So carcinoma which has involved the skin or which has involved the muscles, they are very large and difficult to achieve local control. So they are again a bad prognostic factor. LVI stands for lymphovascular invasion. That means when I'm looking under the microscope, I will see the vessels if they contain any tumor cells. If inside the vessel any tumor cells are there, I will say that lymphovascular invasion is present. So tumor cells present within the vascular spaces is called as LVI. Okay, and it is seen in around 50% of all the invasive carcinoma of the breast. It is strongly associated with lymph node metastasis, and it is a poor prognostic risk factor. Okay, then presence of inflammatory carcinoma, as I've already said, it is having a very poor carcinoma. The 3-year survival is only 3 to 10%. And there's an increased incidence in younger women and African women. Can you tell me tumors in younger and African women is of which type? Whether it is ER or HER2 or it is triple negative breast cancer? Yes. Which of the three will be this? Tumor in younger and African woman? Yes. As I told you, if you go back and see, they are mostly triple negative breast carcinoma and they have a very bad prognosis. Now, response to chemotherapy. Always remember, there is something called as a neoadjuvant chemotherapy. Now, before I am going to do the surgery, I'm going to remove the breast. I am going to give some chemotherapy to the patient so that the size of the tumor comes down. Okay. So 1/3 or more of the triple negative breast carcinomas and HER2 carcinomas, they regress completely with therapy. And these triple negative and HER2 carcinomas, which are responding to the chemotherapy, they have a better prognosis than the non-responding triple negative and HER2 carcinoma. So if the patient is responding to neoadjuvant chemotherapy, it is a good sign. Now, histological grading, yes. Can you tell me what is the name of the grading that we had seen before? Yes.
Nottingham.
Very
Nottingham.
good. Nottingham grading. Now it has how many grades? Yes, tell me. Kitna grade hai? Grade 1, 2 and grade 3. And what are the components of the grading? Tubule formation, nuclear features, pleomorphism and mitotic. Okay, and the mitosis that is there. Now coming to the immunohistochemistry, as I told you, the ER, PR and the HER2 negative tumors, they have the best prognosis. The triple negative tumors, they have the worst prognosis. So we have already seen this point. Special histological type, as I told you, the tubular, cribriform, lobular variety will have good prognosis. Triple negative breast tumors like metaplastic carcinoma will have the bad prognosis. Now, there is also something called as gene expression profiling, which is very important for the postgraduates, but not for the undergraduates. Just remember, the role of gene expression profiling is to identify those ER positive tumors responsive to anti-estrogen therapy that do not require any kind of chemotherapy. So what I want to do, this is very important. This grading is used to find very good quality tumors, those tumors which are having a very good prognosis. So once we find those tumors which are having a very good prognosis, unnecessarily we will not let the patient go through chemotherapy. So for the omission of chemotherapy, we are giving gene expression profiling. For example, we have mama print, PAM50, oncotype DX. Just remember the examples, nothing much over here. Is it clear to everyone? Can we go to the staging of the breast carcinoma? Yes. Now, staging of breast carcinoma becomes very important because in females, it is the most common carcinoma in India, in our country. Okay, it has replaced cervical carcinoma. So that is why any and everything from breast carcinoma can be asked in the exam. So we are going to see the TNM staging. It is very simple, not that much difficult. Okay. So the primary, what does this mean? This is the primary tumor. What is the P? Why we have used the P over here? What is the importance of P? Because this is your pathological staging. There is a clinical staging also. It is a pathological staging. Now, PTX means the tumor cannot be assessed. T0 means there is no evidence of primary tumor. TIS means DCIS and Paget's disease, that tumor which has not breached the basement membrane. Now, there are several stages like PT1A, when the tumor is more than 1 but less than equal to 5 millimeter. 1B is more than 5 less than equal to 10. 1C is more than 10 less than equal to 20. T2 is more than 20 less than equal to 50. PT3 is more than 50 millimeters. What is T4A? Now, this staging becomes very important and asked in your exam. T4A, when the tumor is involving the chest wall, we call it as T4A. Okay, not involving the pectoralis, should involve the chest wall completely, and not just the pectoralis. If there is a formation of an edema, the the orange appearance, ulcer of the skin involvement, ipsilateral satellite skin nodules are there, then it is 4B. If both A and B are present, we call it as 4C. And 4D is your inflammatory breast carcinoma, as I told you. So for diagnosis, more than 1/3 of the breast skin should be involved, and it is basically a clinical diagnosis. Okay, 4D is your inflammatory breast carcinoma. So this is the TNM staging where T, the first thing is the tumor. Then we will see the N. N means the node. So again, the PNX means that the tumor cannot be assessed. Now it is very easy. N1. N1 means PN1A, metastasis involving 1 to 3 axillary lymph node. N1B is when it is involving the internal mammary lymph node, and both A and B together is N1C, that is 1A and 1B. Now N2 is what? Metastasis in 4 to 9 axillary lymph node, or metastasis in clinically detected internal mammary lymph node. Means this over here was pathologically detected. Means under the microscope I am saying. But if clinically you can see that the internal mammary lymph node is involved, it becomes 2B. Okay, and over here one condition is there, pathologically axillary lymph node should come out to be negative. And N3 is basically metastasis involving more than equal to 10 axillary lymph node, or metastasis involving the infraclavicular lymph node. Okay, clear to everyone? Now 3B is when you have positive internal mammary node by imaging with PN1A as or N1B. And NC is metastasis in the same sided supraclavicular lymph node. Now, this very important, might not be asked in your pathology exam, but this is very important from your surgery point of view. All the staging is being asked in the exam because it is the most common breast tumor. And C is your distant metastasis. Okay, when it is present, we call it as M1. Okay, distant metastasis is present, microscopically confirmed. So with this, we have completed the invasive breast carcinoma.